Thank you very much for the introduction and for the opportunity to speak here today about eHealth in Denmark. My name is Hans-Erik Henriksen and I'm CEO of Healthcare Denmark. Healthcare Denmark is a public-private partnership which is owned by the State of Denmark, the Ministry of Health, the Foreign Ministry of Denmark, and some other public authorities on the public side. And on the private side, we are owned by Danish Chamber of Commerce and Danish Industry Association. And our mission is to kind of have the contact with other countries about Danish healthcare excellency, to kind of foster a dialogue about how we can improve our healthcare system. And the underlying background for our existence is to strengthen and promote Danish export of healthcare solutions and also creation of jobs in the healthcare sector in Denmark. If we move to the next slide. The agenda we have prepared today is that I'll give you a little introduction to the healthcare system in Denmark. What kind of setting is it when we talk about eHealth? I'll talk a little bit about the healthcare initiatives we have in Denmark, which is the background why we need eHealth. And then I'll hand over to Lars Hulbæk, who is CEO of Medcom, who will talk about the Danish healthcare data network, but also some experience from the Danish telehealth and telemedicine initiatives. And it was meant that we should also have had Morten Elkjær, who is CEO of the National Danish eHealth Portal. Unfortunately, he had to cancel his trip on short notice due to some family situation. So I'll give his presentation, and I'll also talk about the technical Danish healthcare IT architecture, which is underlying the eHealth portal and is a background for our ability to share data with citizens and clinical professionals. And then we'll have a debate. But you're welcome to ask questions as we go along through the presentation. The Danish healthcare system is universal coverage healthcare system with a focus on free and equal access to healthcare. And that means that when we have paid our taxes as Danish citizens, then healthcare is free to everybody. We do pay 16% out of pocket money for dentist treatment, psychological help, and also some medicine until reimbursement kicks in. But apart from that, it's free to go to the hospital, to GPs, to any specialists. Take the next. If we look at the Danish healthcare system, we have 3 levels. We have the Ministry of Health and their organizations, different boards. We have Danish regions, which is the organization which runs and operates and owns the Danish hospitals. Because we have a public healthcare system, we have public hospitals. We do have a very small private sector. We have 1 real in-bed private hospital and 50 clinics or so it's a very small sector. And then we have around 40 hospitals which are public in Denmark. Then we have the municipalities, and we have 98 municipalities in Denmark. Their responsibility is population health, prevention initiatives, but also rehabilitation, home care, and elderly care. We move to the next slide. An important principle in the Danish healthcare system is that our general practitioner is a gatekeeper. That means that if you have a need for healthcare as a Danish citizen, you go to the DP. And if the DP agree that you should move on in the healthcare system, then you get a referral to a specialist or a clinic or a hospital, and then it's free to move on. If the DP does not agree, then you stop there, or you have to pay yourself if you insist on getting some kind of treatment. And that means that 9 out of 10 encounters actually stops at the DP. So that's a very important role, this role of the DP as the gatekeeper. The funding of the Danish healthcare system is that the regions, they get all the funding from the state or from the municipalities. In 2007, reform, where we changed the role for the municipalities, that was where they got more responsibility for prevention and rehabilitation. And at the same time, we change the incentives, because with that change, municipalities have to finance 20% of the region's cost. You remember the healthcare regions run the hospitals, implementing a mechanism by which, if municipalities are not good enough to do the population health and prevention and rehabilitation, they will have more patients going to hospital, and then it would be more expensive because they finance 20% of the bill. The rest is financed by a block grant from the state, 75% and 5% activity based on diagnosed activity groups. We move to the next. So that was the introduction to the healthcare system. Public, universal coverage, focus on free and even access to healthcare for all citizens. You recognize the challenges on the left side. It's challenges all countries have, at least the more than 30 countries we've been speaking to in Healthcare Denmark over the last 2 years. And in Denmark, if you talk to the Ministry of Health, and they're kind of in a bold mode, they will say, we need to change the way we deliver healthcare. If we continue to have a situation where everybody has to go to hospital if they need healthcare, we will not have enough tax money to pay for the healthcare everybody wants when we got on the other side of 2020. And therefore we have a focus on early detection of serious diseases. We have a focus on screening and prevention. We have a focus on patient empowerment, using the resources of the patients if they have a chronic disease. We have a focus on assisted living, helping our elderly citizens to stay healthy in their own home for a longer time. And we have a focus on telehealth as a means for empowerment. And we have even introduced a national initiative to implement personalized medicine in the public healthcare system, because that can really be a game changer for making the healthcare system more efficient. And then if you need to go to a hospital, because eventually you do, we want to deliver as much procedures as possible outside the hospitals. For that reason, we have increased the number of outpatient treatments and day surgeries. We've reduced the number of inpatient beds. In 1999, we had 98 hospitals in Denmark. Today, we are around 40. And when we have completed our new hospital construction program, we will be around 30 hospitals in Denmark. So we have this focus on doing more outside the hospitals. If we move to the next slide. And this notion of making healthcare sustainable, this notion that we need to change the way we deliver healthcare, it's been around for 10 to 15 years. For that reason, we have increased efficiency in hospital treatment, because all hospital CEOs has been asked to do 2% more patients with the same budget and staff every year. So you can see it's gone up around 10%, 20% over the last 10 years. We are treating 20% more patients with the same budget and staff. At the same time, our cost, our healthcare expenditure is under control. It's even gone down a little bit now. It's increasing, but I think it's actually because we're investing in new hospital construction. We're investing in the future of healthcare, and our hospital standardized mortality rate has gone down. And at the same time, patient satisfaction is actually stable and has increased a little bit. We move to the next slide. And you can see this focus on outpatient treatment on these curves, that we're actually doing better than planned from the green curve. It's better than the assumption. You can also see, because we're doing more outpatient treatment, of course we need fewer beds in the hospitals. We have fewer inpatient stays in our hospitals. And that is, if we move to the next slide, that is actually something that we can see for all kinds of diseases, for cancer, for heart diseases, for COPD, and for diabetes. And if we take COPD, I actually think that this curve here has something to do with a lot of pilot projects and big-scale projects we have done using telehealth to support our COPD patients. We move to the next slide. So because of this effort, you can see that if we look at average lengths of stay in hospitals, Denmark is among the lowest in Europe, with around 4.5. This chart says actually today we're just around below 4 bed days, average length of stay for Denmark. And the aim is to get down to 3 with the new hospital construction projects. Patient satisfaction is high, as I explained, but we do have some issues with cancer diseases where we are not so good, so we have an effort on improving the treatment of cancer. And of course, the number of chronic patients is also rising in Denmark. If we move to the next slide. So right now, what's going on in the Danish Ministry of Health is a focus on early detection of serious diseases. We want to achieve a situation that if you have a cancer disease and you go to the GP, you should be able to go to the hospital the same day to have your diagnosis so we can start the treatment as early as possible. Because if we discover cancer and chronic diseases earlier, we avoid it developing so it gets more expensive and a burden for the healthcare system. There's a focus on the cancer strategy. There's of course a focus on elderly patients because that is the proportion that is getting bigger in Denmark. That's where the healthcare costs are. Therefore, we have a focus on the elderly medical patient. That's again a question about monitoring these kind of patients to find out early if they have a deteriorating condition, regardless of it's being mental, physical, or a new disease that is developing. So our home nurse is actually working with tailored programs for that. And we have an action plan for dementia where actually the Prime Minister is in the seat to make Denmark a dementia-friendly country in the future. And then we have the personalized medicine strategy, as I mentioned. And we have also this year set a target that by 2019, we want to make telehealth national in Denmark. That means that all COPD patients in Denmark should be offered telehealth and home monitoring and participate in treatment from their own home as a chronic patient. The journey towards eHealth started already in 1994 when somebody in the councils at that time, that was a predecessor of the healthcare regions, did a study to see how our nurses and doctors spending their time. And he found that they spent more than 30% finding paper, finding the lab result or the referral or the prescription, not to talk about the medical record. So we went to the Ministry of Health and said, I think the time has come where maybe we could do this electronically. And if we could potentially save those 30% time. So that was the start of the MEDCOM project, which started in 1994. And by 2002, MEDCOM was up and running, where 60 to 70% of all prescriptions, lab results, reimbursement messages, referrals, discharge letters were flowing electronically. And then somebody said, hey, why don't we use all this data to give to the patient, to our clinical professionals? And that was the start of the Danish National eHealth portal, Sundhed.dk, which went live in 2003. And right now we are taking the next steps in our eHealth strategy, which is the 9th eHealth strategy we have in Denmark, where we want to implement international standards, and the aim is really to get to a situation where we have fully national telehealth support to offer to chronic patients. And this is closely aligned, if we go to the next slide, with the assisted living strategy, where the same objective is to get to a situation where all elderly patients and citizens can be offered smart home concepts with technology and solutions that can help them stay healthy in their own home for longer. So with these initiatives, we change the way we deliver healthcare. And for that reason, we changed the role of the hospital, and therefore we are building 16 new highly specialized super hospitals, as we call them. 8 of those are greenfield, and 8 of those are refurbishing existing hospitals. So it's a new hospital structure, which is based on the reduction of hospitals I talked about, and it's an investment of $7.5 billion or 5.5 billion euros, which is ongoing right now. Some of the hospitals have been completed, and the rest will be completed between 2022 and 2025. And then finally, the personalized medicine strategy. You've heard about countries, for instance, Iceland, which have documented the clinical genome of their entire population. A lot of countries can do that. But we are in a special situation in Denmark because our electronic data go back to 1967, 1994 when we started Medcom. We have a national biobank with more than 16 million tissue samples. So the part of the equation where you can compare the patient's biomarker background with clinical genomics is unique for Denmark. And that is why we are embarking on this strategy to implement personalized medicine. It's not something we're doing, it's something we're building a strategy to do in the future. So if we go to the next slide, that was the introduction to the healthcare system and to the initiatives we're taking in Denmark to make our healthcare sustainable for the future. And I'll hand over to Lars, who will talk a little bit about Medcom and the details of the healthcare network.
Thank you, Hans-Erik, and thank you for this opportunity to exchange some experiences. What I'm going to do for the next minutes is I'm going to dig into how we work in practice with realizing these initiatives to share data between the different parties in healthcare and between their IT systems. Because basically that's what we do in Medcom. We make sure that it's possible to exchange data between the many different IT systems, between the many different actors in Danish healthcare. Please. So what I'm going to do is to put Medcom into this in the context that Hans-Erik just told you about. I will talk a little about how we work with standards in practice, some results of course, and then I will look into what Hans-Erik also told you about, how we in practice will work with connecting citizens, this Telehealth initiative for COPD patients where we play a central role. Yeah, that's about it. Okay, Medcom. We are a quite old organization. As Hans-Erik told you, it's founded back in 94. I have been around myself since 97 and the last 2 years as a CEO. We are kind of reflecting how Danish healthcare system is organized because we are owned and financed by the ministry, the government level, the regions, and the municipalities or local governments. So they are in a steering group or a board deciding where Medcom should go. And how do we work? First of all, it's important to know that we work non-for-profit. So we are a non-profit organization, public financed. We work cross-sector, we build bridges between the different parties of healthcare. We collaborate with all IT vendors in the Danish e-health market. We work with standards and infrastructure in the whole country, and we work with practical implementation of e-communication and telemedicine. Now, if you can remember that, you know what Medcom is. Hans-Erik told you about this gatekeeper role of the GP in Danish healthcare. And when we started out way back in 94, our focus was on the GP because when you are a gatekeeper, you have to handle a lot of communication to the hospital, to the municipalities, to the pharmacies, to the laboratories. So that's where we started. The most frequent flows in primary healthcare. And from the beginning, we had only 6 standards in Medcom. We had the referrals and discharge, the prescriptions, the reimbursement to the public health insurance, messages for municipalities, radiology, private specialists, and laboratory. So in the beginning, there was only 6 standards. That was our starting point. Please. So, but as you also already heard, we had this major reform of the public health sector in 2007, where more task was given to the municipalities. And when you move the borders within healthcare, you also change the work of Medcom, because then you have to build new bridges. So we had to make a standard for rehabilitation plan, and we had to make standards on how to communicate when the patient moves from the hospital and out to elderly care in the municipalities. So since 2007, we have a lot of focus on the cooperation between hospitals and municipalities. Please. So one thing is to realize that you need standards. The difficult part of this is how to make it work in the whole country, even being a small country like Denmark. So I think when our model, so to say, is that we need 3 steps to this national dissemination of these things. First of all, in Denmark, we work a lot with consensus. We have to agree in the whole country. Even in a small country like Denmark, that's quite difficult. And we have to agree on two kinds of things. One thing is the standards, the technical stuff. We need a common secure infrastructure to exchange data. We have to agree on that. What's secure enough? And what data to exchange. But at least as important is to agree on the national business case or project plan. To agree on, we really want to do this. And you have to work on both legs, so to say. Because if you don't do that, there will be no market. There will be no interest from the vendor go into this. And we depend on the vendors to implement the standards. They only do that if there's light at the end of the tunnel, so they can sell their solutions with these standards implemented. Having this consensus, you need to try it. You have to show that it actually works. Testing in daily use, and if it works and when it works, you need to have processes for implementation in all relevant IT systems. And then you get to the difficult part, taking it into use by all relevant users. So one thing is about the standards. And again, it's important to know that at Medcom, we are no authority. We are a cooperation between parties. We have an authority in Denmark within the standards. We have a national health data authority making an official catalog of which standards to use in Danish healthcare. So they are there. The governance is in place. But we work with the practical implementation, and we owe 194 of these national standards. Remember, I said we started out with 6. Today we have almost 200 different profiles for specific use in healthcare for the exchange of data. We use different technologies, starting out with UN Edifact back in the 90s, moving to XML, and today we look into online web services and HL7. And you can also see that it's not enough to test the standards or to agree on the standards. You also have to look into test and certification of all the different IT systems. And today we have tested 153 different IT systems in Danish healthcare. As if this wasn't enough, one thing is to make the standards and make them work, but standard changes. So you have to be aware of how to make changes in standard in a coordinated process. You have to agree on the clinical and the technical changes in the standards. You have to freeze your documentation. And then again, you have to go back to all relevant IT systems and test and certify that they use it in the correct way. And then you have to agree on a fixed date for update standards. You could put that in one slide, but in real life, that's quite difficult. But actually, we did it. This is quite difficult. I can read it for you. Today, around 5.5 million Medcom messages is exchanges in Danish healthcare each month. The black curve up here is all e-prescriptions, and that doesn't mean that our e-prescriptions go back to paper. It actually means that we have changed the technology from good old store and forward Edifact prescriptions. Today, the GPs uses a common medication scheme, a central database, and so actually over the years we have changed technology too. The two last curves shows that the hospitals' Medcom communication has been rising over the years. And here you have the municipalities. And actually, their use of Medcom standards is also decreasing a little bit because of the new technology for medicine data. But today we have all hospitals, all GP clinics, and all municipalities connected in this system. And in a European level, that's quite good. If you look into the GPs, the European Commission a few years ago made this benchmark showing that when it comes to health data information exchange, the Danish GPs are number 1, and also when it comes to sharing data with the patients. So that's where we are today. I think French is around, in 2013, the French is around the average of the EU countries. So it actually works. And it works every day, it works every minute. But of course, there's also room for improvement by us. And our focus for the next 2 years will be introduction of a quality management system for this test and certification cooperation with private IT vendors. You can imagine what happens when you go from 6 to 200 standards, and the changing in these standards, you have to be make a very coordinated effort. We also look into moving to more modern international standards, mostly HL7, and we look at this connecting citizens. In the work of connecting citizens into the system, we have the focus of the COPD patients. We have had a large-scale pilot project in Denmark, and the status right now is that we have around 2,000 unique patients in a national database and around 600,000 specific home monitoring results in the same database. So it's working. We are not at all in 100%, but it's working. In this work, we have published some open source code implementing continuous standards and HL7 standards. We have this national database for home monitoring results accessible as our secure infrastructure. We have interfaces both for collecting these data from different telemedicine systems and also for sharing these data with the patient record system, both at hospitals, GPs, and municipalities. So if you go back to our 3 steps to national dissemination and try to use them on the case of telemedicine for COPD patients, you could say that we have the standards and the infrastructure in place to ensure this multi-supplier strategy. We have this national plan, as Hans-Erik told you about, to ensure the market should be there. We have had a large-scale pilot project showing that this actually works. In the summer of 2015, the national business case was recalculated. And now we are looking into a situation where we, from the start of next year, will begin this implementation of these standards in all relevant IT systems. And hopefully we will be able to support this national dissemination to the end of 2019. So that's the plan. So, looking back on our history, I think it's important to realize that this is actually possible, but also that it implies huge investments, not only by healthcare organization, but also by the IT vendors. And I think that our history also shows that it requires strong leadership. You have to have the courage to select the areas where you will disseminate. We have now selected COPD. Let's see if that will do it. But we also need persistence, ongoing support all the way, and patience, because this takes time. It took us around 20 years to reach this 100% in the field of the basic communication. 20 years is too long. We can agree on that, but you cannot do it in 2 years. You have to be patient. And I think perhaps my most important slide is that you also need to be pragmatic. It's not enough to be correct in all these technical senses. It says, what do you mean? It's a bit muddy. Because if you want to disseminate in the whole country, you have to be pragmatic, and it will be muddy. Thank you. That was my words.
Thank you very much, Lars. And now we'll continue with Sunday DK, the national eHealth portal. I talked about the national eHealth portal being established and going live in 2003. And actually today we have 1.5 million unique users every month in a population of 5.7 million. And it's going up every month. So you can see it's really a portal that's being used by citizens, patients, and clinical professionals. If we move to the next slide. So What can I do with the portal? Well, as a citizen, I can access all my clinical notes. So I can see the clinical notes from the hospital, from the GP, from all the clinics, actually a couple of days after I've been there. I can see all the referrals. I can see all my medicine, regardless of where it was issued. I can see which medicine I got from a pharmacy. I can see all my lab results and all the referrals. So I actually have full access to my electronic health record as a citizen and as a patient. There are also other facilities for citizens. There's a medical handbook, so I can look up different diseases before I contact the GP. There are other facilities I can sign up as a donor if I want to do that. There's a log where I can see which clinical professionals took a look at my data, so I'm actually involved in the data security myself. But establishing the eHealth portal was not only about citizens, it was also about the clinical professionals. And if we go to the next slide, from the beginning, there were GPs working at the team of Sundhed DK to ensure that there would be value for the clinicians built into the portal. So they can see the latest on education and new research for clinicians, so they can actually use it as a tool to keep their knowledge up to date. And if you go to the medical lexicon, which is aimed at the clinicians, you will find much more Latin words because it's actually built for them to ensure that they are up to date. But clinical professionals, they can access the same data as I can do as a citizen. So if they have a citizen or patient in treatment, they can see all the clinical notes, medicine information, and they actually get their medicine information as part of their own electronic medical record or EHR in the hospital. So if when they look up the medicine list, they have information about all the medicine this patient has got prescribed, regardless of where it was in Denmark, and they can see which medicine was dispensed from a pharmacy and so forth. So as Lars explained, we actually have a national medication database where we share all medication in the whole healthcare system of Denmark. And then they can see all the data I mentioned before, lab results, clinical notes, and so forth. We go to the next slide. So this is actually how it looks like. It's in Danish, but you have an overview where you can navigate between the information. And you have this card which actually tells a little bit about the security system, and that's a question I often get, especially in Germany. How do you make data secure? And it's actually based on free codes and a physical token, a key card or a key generator. And it's the same security system as that we use for our bank information or our tax information or any secure contact with public authorities. It's a national security system. We move to the next slide. This is a little bit difficult, but that is actually the overview of patient's electronic health record. And from that overview, you can dwell into the information about which clinics and doctors exist in Denmark, which hospitals are there, or you can dwell into clinical notes or lab results and so forth. And there's a special reason why it's constructed in this way, and I'll talk about that later. But that's an example of the data and how you access it as a citizen. We move to the next slide. So where do we go from here? And if we move to the next slide again. What they're working on in Sundhed DK is to be able to share even more data in the national eHealth portal. It's also always improving the user friendliness and focus of the portal. And it's to continue getting more users. Even though we are at 1.5 million users, we still have part of the Danish population which will want to learn to use the portal. And it's also, we're actually working on a new version of the security mechanism, even though it's not a problem what we have today, but we want to make it even easier to use. And this is a slide where you can see how it has gone up since in the early days in 2003, not too many users, but really after 2010 it has taken off, and it's a tool being used widely in Denmark. So as Lars was also explaining, the underlying reason why we can do this is that we have strong national strategies. We have a culture where the healthcare authorities, the Minister of Health, Ministry of Health, Danish healthcare regions and Danish municipalities over the years, and after having had 9 different IT strategies for healthcare, they have come together and they stand behind and agree on what to do. And that's important because one of the issues for many countries, it's the stakeholder managing in healthcare, which can be difficult. To get everybody in a healthcare system to agree, this is what we want to do. And as Lars explained, it's the same with coherent funding and getting the data sources where Medcom has been fundamental also for realizing the eHealth portal. And then on the next slide, it's also about this culture of trust. Danish citizens trusting that it's better to share healthcare data. Danes will rather have the risk of somebody accessing their healthcare data who should not do it than having the risk of going to a hospital where they know nothing about you and have no idea about what disease you have. You can see also that DK, the national eHealth portal, and also Medcom has helped drive up the level of IT in Danish hospitals. Many Danish hospitals are high on the HIMSS EMRAM scale. You can see in average we are among the highest in the world. And that is because when we needed to establish a health data network and an eHealth portal, we also needed to demand that hospitals use electronic health records and that GPs and clinics use electronic systems. We move to the next slide. And the next again. So another area of the future is of course going mobile, because today the younger generation, but also the elderly generation in Denmark, they want this access not only from a web browser, but also from the tablets and the smartphones. So that's definitely one priority for the future. If we go to the next slide, and then it's also this question about making it real time. Until a few months ago, the way it works was that there was a 14 days delay when you access the eHealth portal as a citizen. It was moved, is it 2 days? Was it 2 days now? It was moved to 2 days, and there was a lot of fuss and protest from the doctors saying, no, we cannot allow citizens to have access only 2 days after visiting the DP or the hospital. But it stands, and I think the argument from the Minister of Health is then you need to be faster to ensure that if it's a serious disease, you talk to them first. So that's a way to push the healthcare system. And that's actually where we're going, that we want more real-time sharing of data. We move to the next slide. And then, of course, supporting patient empowerment, supporting the telehealth and telemedicine projects. One reason why we can do the telemedicine projects, it's not only about devices in your own home. It's not only about having the infrastructure. It's also about having the electronic data. So if a COPD patient uses a spirometer and need to compare data in their home, then we have all the electronic data that is necessary. So eHealth and what Medcom is doing is also fundamental in that respect. We move to the next. And then what we're seeing in Denmark is that all our campaigns and population health and use of DK, it works very well for the well-educated part of the population. And therefore we have special initiatives to get those who are not so well-educated or have social bias on the wagon too. Because if we don't use more nursing resources and resources on that part of the population, then we cannot move our healthcare system. And then, of course, I talked about the productivity and the patient satisfaction. Definitely the eHealth portal and the sharing of data in an electronic way has been an argument and a contributing factor in this. And you can see that when it comes to connectivity and eHealth, Denmark is also rated as number 1 in the world. So if we move to the next and the next. So the last thing I want to talk about, and I'll do it as fast as possible so we also have a time to dialogue, is the technicality behind the eHealth portal. And if we go to this slide, this is actually the national service platform, because as Lars explained, the way we started when Medcom began was sending messages from a DP to a hospital, for instance, a prescription, or a prescription from a specialist to a hospital or to a pharmacy. Then we found out that it would be better to put all the prescriptions in one database, because then we could also use it to get knowledge about how we prescribe medicine, and we could create this system where we share the medicine information to all our electronic patient records. So that led to the idea to gather all the data sources we use in the healthcare system in one national service platform, which is actually called the National Service Platform. So in this system, which is managed by the National eHealth Authority, we have our patient master index, the civil registration number register where we identify the patient. We have the medical authorization register. We have a register of providers. We have the shared medication record, which is actually this national database with all the prescription and medicine. We have the consent database where you can actually give consent to sharing data in the eHealth portal. We have the log where you can see who used the right to see my data. We have the vaccination register and so forth. And if we move to the next slide, and this national architecture with this was actually one of the reasons why we could upscale our telehealth projects, because what do you do when you start working with telehealth and then you suddenly find out, hey, we have a new data source, namely devices that deliver data. Well, with this national architecture, we could just add a database that gather these data. And that is actually what we did and what Lars was talking about. And that way we were able to now share data from devices and take the step to make telehealth a national thing. And we did the same thing with the National Image Index. So I think it has been fundamental to Denmark to have this notion and architecture of a distributed national service platform, which has allowed us to share these data on a national level. If we move to the next slide, you can see how data is delivered. It's actually delivered from the 5 regions. They have their own local copy of the National Service Platform. Data is delivered from municipalities, National Service Platform, the medicine system, the open telehealth system, and from the DPs. So that way we can have local data and we can replicate it to a national service platform where we share it. And if we look at it from a region perspective, all the regions where there's typically 9 to 15 hospitals, they have the same electronic health record system. So if you're in one of the regions, you use the same system, but you replicate data back and forth from the national service platform. And I think that was the conclusion of this introduction to SundhedsDK and the technicality and architecture behind it. And I hope there's some time for debate and questions, and I'll hand over to Lionel. Thank you very much.
Please have a seat. That was amazing. Thank you very much. Very interesting. As you may know, our Ministry of Health announced yesterday our e-health strategy. This seems quite a guidelines for her to implement e-health in France. Do you meet a lot of people from France to see your healthcare system and to get some advice?
Yeah, one of the things we do in Denmark is, in Healthcare Denmark, is that we have a visitor program, and we're seeing more French delegations coming to Denmark. So from my perspective, yes, definitely. We're seeing that interest. We're also seeing that interest from many other countries. This spring, we've actually been in contact with 5 ministers of health from different countries which have visited Denmark. So the things we do and the way we do it in Denmark raise a lot of interest from other countries.
I saw on one of your slides you're working with pharmaceutical industry. Which kind of relationship do you have with the pharmaceutical industry in Denmark?
First and foremost, we have a tradition for a close public-private partnership with the pharma industry. If you think about Novo Nordisk and Lundbeck, their existence is actually due to a lot of close cooperation in research. But when we talk about e-health, we actually try to not involve the pharma industry too much in that, because we want it to be independent. I don't know if you have any comments on that, Lars. Yeah.
Thank you very much. This was really interesting. I have a question for you, Nicole Hill, Alcatel-Lucent Enterprises. What was the trigger or the driver that led you to agree on to move from 9 systems to 1 system, besides your culture, which is consensus in Denmark? Were there other elements that made everybody agree on that? Because this is quite a challenge. When you say that you had 9 systems?
But the point is that we still have 9 systems, yes. But we have an architecture which allows us to have 9 systems and still share the data. However, there's been a lot of consolidation of systems, and I think Lars can talk a little bit about that, because Medcom has also been following that development.
Yes, indeed, there has been a consolidation, but still there is a market with competition between systems, and I think when you have been in the game as long as we have, I think we have both seen systems that and vendors that was top of the pop at the end of the 90s, and today it's other systems being the best ones. So I think the competition between vendors is still important to improve the IT systems for the users. When it comes to the start of all this, I think if we think back to the early 90s, actually it was the clinicians themselves, and especially the GPs in Denmark, a group of GPs really wanting this to happen. I think that's very important. It didn't come from us. It didn't come from the IT people or the IT organizations. It came from the clinicians, and we tried to meet their needs in a very close cooperation. And if you take that approach, you also have sometimes to be pragmatic about the actually technical solutions. But that's the way to start it. You have to find solutions that actually make sense for the clinician's daily work. I think that's where it all begins.
I had a part of my answer, but it was difficult to educate people at the beginning, or not, or public understood very well this system at the beginning.
Are you talking about the clinicians or the citizens?
Citizens. And both finally, but yeah. Citizens firstly.
I think that, again, to understand how we succeeded, I think it's important to understand that before this process of building bridges between all the parties, there actually was IT systems in use in a quite big scale in Danish healthcare. The hospitals has been using IT systems for administrative purposes since the 70s. The GPs began by themselves to build and buy a patient record system in the 80s. And then the municipalities came in the 90s. So we didn't start by exchanging data. It's so funny because you cannot exchange data between IT systems without IT systems. So you have to have IT systems in place at first. So just to say that if you are already used to using a patient record system, it doesn't make that big change if you communicate to.
Hello, my name is Patrice Castet. I'm from a small company called Accitania. We're based in France, and we offer a new service to track the breath of people through new biomarkers based on natural breathing. It's something completely new which exists since 4 years, and at the moment we work with some French hospitals for lung transplanted people, COPD people, and also asthmatic people. The idea is to prevent crisis, for example, for COPD people and for asthmatic. So I'm very interested by your telemedicine program, which is at the moment busy taking off in Denmark, as far as I understood. So I would like to know how do you follow COPD people in this program?
How we do it, or just
yes, how do you what do you do exactly to track the state of health of COPD patients?
Basically, it's a matter of monitoring weight and saturation, and blood pressure. That's 3 factors being transmitted from the patient home. And then we have some questionnaires. And our task in Medcom is to make standards meeting those needs for exchanging data. So we make specific profiles of HL7 standards for exchanging these data, and questionnaires to collect them and to share them both with the patient record systems and the eHealth portal for the citizens himself. So the game is that there's room for vendors, and the regions and the municipalities should make some tenders where they ask the market to come with solutions, and including these national standards.
Yes, Thierry Scheverbeck. I'm the head of the rheumatology department in the hospital of Bordeaux, and I work with Accitania. Yeah, with Mr. Lanus. Yeah. A very brilliant presentation. First, I don't understand. You have 3 main partners: the patient, basically, the GP, and the hospital clinicians. But do you have a private specialist in Denmark or not? And if yes, how do you implement them in your system?
We do have private specialists. What we don't have is many private beds, so to say, but we do have private specialists, but also in a high degree financed by public health insurance. So they are in this network too. They receive referrals by our standards. They send out discharge letters. They use our standards for requiring laboratory and also receive laboratory results in a standardized way. They use this common medical database. So they are a full-blood part of this system. And again, the Danish healthcare is very regulated. So being private specialist, you have to have agreements with the Danish regions, and if you would have such an agreement, you should also be able to communicate your data in this system. That's part of the deal.
Any other question?
Good afternoon. I would to know, if you know, how does it work with a patient from the other European country? Because one thing is that your administration is really like electronic administration, which is not reality in, I think, all other countries in Union European. And the second thing is it's money, because if you have a lot of technology like telemedicine, there's a lot of country that we don't use it. And so I think that there's also a problem with like assurance and all these things. So how does it work?
It probably doesn't work.
Okay.
Well, I think there's 2 questions, answers to that question. If you move to Denmark as a European Union citizen, you are assigned a Danish patient master index number, CPR number as we call it, and then you're just treated in the healthcare system as any Dane. If you're visiting Denmark, then you're treated in the Danish healthcare system, and your health insurance, if you're a tourist, will pay for it as it is for us Dane if we go to another country. And then obviously you are not part of the electronic healthcare system in Denmark as such, but then as a tourist you're just treated and then you hopefully go home again.
I'm a fireman, and I would like to know if your portal is managing health informations that are transmitted by human sensors to emergency services. If a patient is ill at home, this patient wears human sensors on him. Is it possible for emergency services to get the information?
That depends on, are you talking about these variables you use? Are you talking about a sensor which you have got from the healthcare system for a specific disease?
Yes, just if a patient has a cancer, is at home, he wears medical sensors on him. Medical sensors are managed by your portal, if I have clearly understood, or some of them. Is it possible for emergency service to know what is going on at home on the patient? And so as to adapt.
Potentially, I mean, the electronic infrastructure we have makes this possible in principle. The data that is shared is the data that is going on in the focus projects, which are focusing on chronic diseases like COPD, diabetes, and so forth. But I mean, it's a question about the hospitals which today have that connection with cancer patients, for instance, having these wearable devices attached to them to just say we want to share it in the national clinical device database, and you could actually do it. By the way, in ambulances, we have a solution where we have an electronic medical record and we have connection to the ETD, and we send that to the hospital as the ambulance move along. They also have video connection in the ambulance, so they can have a video consultation. They can switch on the specialist who can actually see what's going on to the patient and then advise the paramedic in the ambulance. So we're also working on that field. So maybe in some years in the ambulance they also have this data.
Lars Anseric, thank you very much. I think we've run out of time, but you stay there for the next 2 days?
Unfortunately, we have to leave today.
You have to leave today, okay. For you can visit Denmark anyway. You can contact, and you got a
Healthcare Denmark website. As I said, we have a visitor program. So if you're a delegation, you want to go see for yourself what we're doing, you can request a visit through our website. So that's definitely a possibility.
Okay. We will build a group to come to see you. Thank you very much.